And so this next and final session focuses on how we create the evidence and policies toward a better future in mental health care. We heard Ben Miller earlier lay out the challenge as well as his roadmap. We've heard from 3 innovators with novel approaches, and now we will get to hear from our panel of experts that will help us lay out a research and policy agenda and think about a way forward. So let me introduce our 4 panelists today, along with our moderator. So first, I'll introduce Lynn Bufka. Lynn is a Senior Director of Practice Transformation and Quality at the American Psychological Association. She focuses on the development and implementation of programs and policies that support and expand opportunities for professional psychology. Glenda Wren Gordon is President of Mindula Clinical Services and previously served as the Founding Director of the Kennedy Satcher Center for Mental Health Equity at Morehouse School of Medicine, where she is also currently an adjunct associate professor. Cecilia Livesey is United Health Group's first Chief Mental Health Officer and Assistant Professor of Psychiatry at the University of Pennsylvania. Previously, she was Chief of Integrated Services in the Department of Psychiatry and a Fellow at the Center for Healthcare Innovation at the University of Pennsylvania. Then we have Victoria Saltis Jarrett, is the Carol Mord Ross Distinguished Professor of Psychiatric Mental Health Nursing at the University of North Carolina at Chapel Hill School of Nursing. She's practiced psychiatric nursing for over 35 years and continues to focus her clinical practice, teaching, and scholarship on mental health care approaches. And then we have the fearless David Mandel, who is going to lead this discussion today and help us bring this all together. David is the Kenneth Apple Professor of Psychiatry and Director of the Center for Mental Health at the University of Pennsylvania. He's trained as a psychiatric epidemiologist and mental health services researcher. His research focuses on improving the quality of care that individuals with psychiatric and developmental disabilities receive in their communities. And so I will turn things over to David, who has the challenging task in front of him of bringing this incredible group of minds together around really trying to chart a research and policy agenda to help us overcome so many of the barriers that we heard about earlier today. So take it away, David.
Thank you, David. And thank you very much to our experts who've agreed to be on this panel and to share your thoughts about what we've heard today. We heard a very inspiring talk from Ben Miller about what the challenges and potential solutions are to addressing our fragmented and sometimes dysfunctional mental health system in the United States. And then we've had 3 innovators talk about new strategies that they are using to try and address some of those challenges. And I'd like to start by asking each of you to reflect on what you heard as the common themes in some of those sessions. And we'll get more into this later, but briefly, do you think that there are policy or practice or research steps that we should be taking next? And I'm just going to go in the order in which you appear on my Brady Bunch screen. So Lynn, do you mind starting?
Sure, I'm happy to start. I'll try not to say all my thoughts because I don't know about others of you, but I thought Dr. Miller said many of the things I was thinking about originally, so we'll just expand on that. But I think a couple of the challenges have to do with the key question of where people are when they access care. And our model right now is you have to go see the specialist mental health people typically. That's not where folks are. And the innovators were trying to come up with opportunities for how to get care to individuals, but that's not systematized across the US, across any sort of system. Perhaps contained systems like Kaiser or the VA do a better job with that. But in general, that's not most people's experience. So we really need to look at how do you leverage these different kinds of innovations so that people can access the level of care that they need at the time they need care, so that we're not having everybody get care at the crisis point or at the point of diagnosis and extreme symptoms, but get care that might be appropriate for them at an earlier point in their process. And then of course we have to figure out how to get this paid for, right? Like right now it's a fee-for-service model largely. It doesn't really cover a lot of these kinds of innovations in ways that make it accessible broadly. So those are 2 of the key questions that I think are really important for us to address and look towards resolving.
Thank you very much. Linda, I'd really be interested to hear your thoughts as well.
Yeah, I mean, I'll start off and just look forward to building as we go. I too saw that theme of trying to solve a problem that our current system isn't doing. There's so many ways to do that because there's so many problems. But thinking about, the range of severity of symptoms is very challenging. And one of the things that the startup and private equity industry has done is they can come in quickly. They, over $1.5 billion was invested in mental health in 2020 alone. So there is a hunger for solutions in this space, but that's also magnified the chasm between what we would consider usual care and the leading edge of innovation. And that's figuring out how to close that in an equitable way. I love some of the themes around thinking about equity and who's being left out. How is this solving equity challenges is really important, looking at outcomes, but filling in those gaps and trying to figure out how do we really come up with solutions that are sustainable, because there's a lot of interest now, but that's not going to be permanent if we can't have our fundamental system evolve in payment reform. And then one other thing I'd love to hear us expand on is the fact that we do have workforce challenges, but about half of our behavioral health workforce is completely opting out of the insurance frame. And so I'd be very curious to hear what people think about how maybe some of these ventures can help bridge that gap for the providers that are in private practice land. Can we find ways to make the workforce that we actually are training to be more equitably accessible to people who need care?
Thank you. Really good points. Victoria? You're on mute, Victoria.
There we go. Sorry about that. I guess I wanted just to echo what has already been said, but in terms of just words, access is one that comes to my mind, and in particular, making sure that federally qualified health centers are not left off because of what's happened previously with the CARES Act. They were actually left off the first CARES Act grant. So that's important to make sure that all legislation moving forward considers those that need it the most. Accountability is another big word for me, and that's really focusing on who's holding people accountable for monies that are apportioned. And then lastly, I think the innovation piece is, and I just keep going back to reimbursement, that it is an issue, and that is why people are moving to cash based practice. So I think that is another piece that we have to look at as being able to serve more people across the board.
Thank you so much. And my colleague, Cecilia.
Yeah, so also echoing what people say, I mean, I definitely see the access that, each of these innovations expands the number of people who can get mental health care, but I think also thinking about like access for providers. So new ways that providers can reach people where they are, like a new workforce and volunteers to support patients and allow clinicians to work at the top of their license, like Minnie was telling us about. I mean, I thought that was fantastic. And new tools to help us understand how patients are doing and kind of augment interventions and empathy, like John was talking about with coaching parents in their natural habitat. And I was thinking, actually, I need one of those little Bluetooth things at my dinner table. And I think, equity, as Glenda said, because we've seen that telehealth has expanded the reach of care into these underserved areas, and that, 80% of the US has smartphones. And so that's a great channel to use to deliver technology solutions like Derek was discussing with asynchronous message-based care. But the other thing that I wanted to mention was I heard a theme of care personalization that I really liked, just thinking about how each of these innovations can help us become sort of more targeted about what's the best type of care, what's the best type of provider, what's the best medium for each patient.
Thanks, Cecilia. So I heard from all of you issues related to access, to equity, to issues of professionalism, and Victoria, you also brought up the issue of accountability. And I'd like to maybe think about those individually and how we need to think about policy if we want to address these issues, especially with these innovations in mind. And so if we start with the idea that we get what we pay for, how do we think about the tension here that several of you raised and that our innovators raised about the format through which intervention is delivered, whether it's remote or in person, integrated with other kinds of care or separate, and also that the tension of who delivers it. And several people brought, and I see questions in our audience a lot about concerns about access versus deprofessionalization. So what are the policy issues we need to think about as we consider these new modes of delivering care and a new group of people who might deliver it? And I would open it to any of you who wish to take a stab at that.
I can start really just by highlighting two pieces of legislation right now that's being considered that's relevant to this. The first is the Equity in Mental Health Act, which a large portion of this has to do with increasing funding from NIH and NIMHD in particular around mental health and mental health disparities. Probably like many of you sit on study sections where you're only really funding 20% of very high qualified applications that come through, and that contributes to that gap between what other entities that have resources can quickly implement but maybe don't have the skill set to research versus researchers slogging away, trying to get great ideas funded, especially on the implementation and efficacy side. So that's one piece of legislation that also includes increased diversity and training for diversity within the workforce, which is also important to fill in those gaps. And then the second piece of legislation is evaluating disparities in outcomes of Telehealth Act, which is framed in the context of COVID, but I really think speaks to some of the things that all the presenters have talked about today in terms of like this promise of telehealth versus the question of, is it really achieving its promise, and who's really being left out, and what type of even infrastructure outside of healthcare might be required to increase true access for rural populations and other disparity populations. So I just wanted to point out those two pieces of active legislation for people to, on the advocacy side, look at and think about how you might be able to get some support for that.
Would any of you see any, if we were very excited by the promise of remote care, telehealth, either synchronous or asynchronous, and we needed to make some changes right now to instantiate that, to make sure any gains that happened during the pandemic because of the relaxation of various regulations weren't lost, what would you want to see put in place?
And I think number one, you have to have payment equity. You cannot have differential payment for remote versus in-person care, because for most clinicians providing mental health services, the difference in terms of the cost of providing care really doesn't differ, whether it's in-person versus remote, because you're now paying for technology that you perhaps aren't paying for in the office in the same way. So that really should just be a no-brainer. Let's have equitable payment, the same payment across the kinds of care that's being provided, whether it's via remote or in person. We don't have payment models for other kinds of technology care, right? And it often falls on the burden of the person seeking it, whether it's the asynchronous apps like Talkspace and others, whether it's different kinds of providers who aren't within the reimbursable network, right? So we don't really have good models for that, and that's going to be really important as well. I would love for us to not have a fee-for-service model for mental health care. But as long as we have a fee-for-service model for mental health care, we need more codes that reflect the range of care that different providers can provide. So as a psychologist, I don't have any differential in terms of the intensity of the kinds of services that I provide. I either provide psychotherapy or I don't. I do a diagnostic evaluation or I don't. I don't have a range of codes to reflect some of the things that physicians might do around evaluation and management questions. And so we need to have codes that reflect better the kinds of services and the depth of services that people are providing as well. So I know that my organization, the American Psychological Association, is certainly actively engaged in trying to expand the kinds of codes that are available and appropriate for psychologists and other providers who are not physicians have access to, but that's one component of it. And that's working within the fee-for-service model. And we really need to have access to models beyond that to really do the kinds of innovative care that has been talked about.
Thanks. So Cecilia, as the first chief mental health officer at a major payer, how do you think about these issues related to payment for these kinds of services?
Yeah, well, I wanted to also touch on, because you mentioned care integration and also, paying for different models. And I do think that we're, moving in the right direction with things like the collaborative care codes that pay for sort of team-based service and allow different types of providers to be, involved. But I think, looking at kind of value-based payment, really understanding the data on it, making sure that it's not, in the case of mental health, sort of a way to sort of decrease mental health, which is already an underutilized service, but a way to increase it, and also to make sure that we don't always tie mental health to other outcomes, right? That we don't always say, let's make the depression better because it'll make the diabetes better, because you never say that for breast cancer, right? You don't say, let's do this surgery because it's going to make someone's hypertension better. So I think we need to sort of really get into the details of looking at these value-based models and make sure that they're incentivizing the right type of mental health care.
What is the right type of mental health care?
Well, I think, in my mind, it's getting people the right care at the right time with the right provider at the right intensity. And so, for example, I had a patient who had been to 9 different providers, who had post-traumatic stress disorder, had been to 9 different providers, none of whom had done evidence-based psychotherapy for post-traumatic stress. And it wasn't until they were referred. And that was a huge waste of time, not only for the patient, but for the provider, for the payers, for the system. And so I think it's that ability to sort of have a little bit more precision in our care pathways is going to be kind of a win-win-win for patients, providers, payers, and caregivers, because they're the ones often helping to navigate the system.
Victoria, you brought up this issue before of accountability, and even as we think about increasing access, and I want to come back to a question. I see a lot of tension in the questions that the audience is asking about, and we heard it from Ben Miller about using a lay workforce. We heard it in the Sunshine calls, and there are folks asking questions about peer support, all of which may be great options. How do we think about that tension about who should deliver care? And Victoria, how do we think about it within the context of the accountability that you raised?
I suppose that we need to first and foremost consider that everyone has a role. So it has to be team-based. That way we're working and educating as well as training different folks to provide different skills for the individuals. So the accountability would start with the leadership. And that's what I've always believed is if you don't have a good leader, you're not going to have, it's going to trickle down. So it's really important for accountability that's a piece of it. The other part that I'll just throw in, and I could talk about all day, is the notion of not-for-profit. We really have to look at healthcare as not being, a profit-based entity. When it becomes a profit or for-profit, then what we end up finding out is that people are trying to do smarter and see more patients, and I've seen that with telehealth as well. So that would be part of what I would consider for accountability is really looking at models that are they're looking at quality versus quantity, but it always seems to like disappear and be buried. So those would be things I certainly would consider.
Sorry, Glenda, you brought up the issue of equity before, and I think there's a lot of folks who we heard today talked about some of these strategies as increasing access. How do we make sure that that some of these new practices and the policies that might accompany them don't unintentionally exacerbate disparities we see in care rather than ameliorate them?
I mean, that's a great question and something I spend quite a lot of time being concerned about. My recommendation is you have to think of it up front. It can't be an after the fact app design, oh, wait, what's happening to these other populations? And as you're innovating on the front end, noticing who's coming in naturally, it doesn't mean that your solution needs even a substantive adaptation. So when you think of it on the front end, you're including people in disparity populations on the front end of design. So from the first steps of conceptualization, and there's been, I mean, we've talked about so many interesting innovations that have stayed out of mainstream. We've had research on text-based interventions for, Latino populations for a long time. There's a lot of knowledge and research out there that just hasn't had the financing to really prove itself at scale. So I think there's a balance between, that for-profit, some of the benefits is that they can sort of make these investments to bring things to scale. You just have to know where to look, and you have to know who to have a seat at the table, thinking about, gender differences in access to care and acceptability to care. We know a lot about engaging communities, particularly around mental health care, which is really substantively different from medical care in that most people have an idea about their mind. I don't have much of an opinion about my heart or my pancreas. I mean, it does what it does. If it was broken, I'd figure out why. But everybody has like a thought about how their mind works. And so that's why it's so hard on the front end to figure out how do you sort through all that and come up with solutions. And so, to have a culturally centered approach, if that's something that you value, you have to be on the front end of design, including people in the design process, informing how you're developing it. And that's the most efficient way of really paying attention to equity. If you're not willing to do that, at least measure the demographics and report on it. I mean, I've read a lot of papers, don't even show the racial and ethnic background of the population. So I don't even know how to interpret, does this even apply to communities that I might care about, health disparity populations? And we have issues right now across our health system even, and getting self-reported racial, ethnicity, sexual orientation, and gender identity data. So measure, at least if you measure it, you can look at the differences, but the better approach is to try to engage those populations up front in design so that you can really develop interventions that are acceptable from day one.
Glenda, Victoria, and Cecilia, you brought up different parts of the same elephant here. So Glenda, you just mentioned the idea that we have interventions for which we've had data for years, that they work for particular populations. Victoria, you brought up the issue of use of evidence-based care, as did you, Cecilia, and this issue of payers being rightly skeptical of interventions that perhaps don't have a lot of evidence. But so I have sort of two questions that may be flip sides of the same coin. The first is, what do we do about that? What are the policies and practices we need to put in place to do a better job of speeding the use of these evidence-based interventions in practice? And Cecilia, what's the minimum bar? What is it that we need to provide as researchers that will get policymakers to take notice and to think about covering?
Well, I think first and foremost is efficacy, but I did, just based on what you're saying, David, and what Glenda was saying also about equity, I did want to bring up a point about data, because all of what we're talking about, all these innovations, a lot of it is based on data and new sort of data sets that we need to be very transparent and think about the ethical framework around that, and being very careful about bias and creating kind of machine learning loops in a lot of these new technologies that potentially could strengthen that bias. So, when we're talking about getting people the right care at the right time, or, targeting certain populations with an evidence-based intervention that works for them, that's all going to be based on data. And so I think the role of data and AI in healthcare is definitely not one we're going to deep dive on today. But I just wanted to mention it because I think it touches on sort of all the facets of healthcare that we're talking about in terms of research and policy and payment. And ultimately, what you're talking about, David, is how do you sort of prove these points? And it's going to be with data, and it's going to be with efficacy data and value data and things like that. But how we think about that data and use it, I think, is becoming increasingly complex, and especially from an equity standpoint.
Other thoughts from folks about the moving some of these interventions into practice, or thinking about what our bar should be?
I think Cecilia was...
sorry, go ahead, Lynn.
Okay, Victoria. I think Cecilia was raising some important points about data. It's in building on even what Glenda said earlier, is sort of who is involved in the research, right, is so critical. We have on the academic side, we struggle so much with, we want to have the perfect data. We want to have all the questions answered before we move forward, and we can't. And especially can't with technology, because technology is going to change faster than our research is going to get out there and get done. So we have to come to terms with some way of saying, yes, this research, this data is sufficient. It has enough rigor, it has enough acceptability for us to move forward to make decisions, while at the same time acknowledging where we need to build. We're very good, certainly psychologists are, I can't speak for all disciplines, but we're really good about saying all the limitations of everything that we do and every study that we put out there. But we really need to be able to take the important findings and put them into action without all those qualifications preventing us from making any step towards a change. So I think that's going to be one of the important things to think about. And I think that's going to be important for researchers to think about as they do the work that they're doing, as they're building on their research, as they're thinking about what do I know, where can I, and who needs to have this message, what kinds of findings do I have that are sufficient to start moving towards other kinds of practices, while also recognizing we always have more to learn. We need to know more about all kinds of different populations. We need to understand more about levels of care and severity and how that intersects. But we can't let the notion of searching for perfect data get us to the point that we don't do anything policy-wise.
David, if I could add just one more thought on that, because I think we've come so far in a relatively short time in terms of adoption of measurement-based care in behavioral health. Certainly when I was in training, it was not, as widespread now. And I think that will make it maybe easier. I'm curious to hear Cecilia's thought on that too, because we've kind of talked around this notion of fee-for-service versus value-based for behavioral health. And when ACOs and all that started to come out on the health side, behavioral health was often left out of the equation because our measures were process measures. Now at least we have PHQ-9. Everyone sort of knows what that is now, and it's a good leading indicator probably of, it's not perfect, but I'm glad that we're actually using these measures. But that will be the great equalizer too, to answer the question of, can you get effective outcomes with the lay provider? I never worry about any of those turf wars because there's so much need. There's just so much. Like, please take the piece that you can do and do your part, because our society needs mental health care across the full spectrum. So I think those clinical outcomes and those quality measures that are actual functional outcomes and clinical outcomes, I think is one of the exciting things that we can continue to support. It's not easy to implement, but I think as much as our field can continue to invest in that, we will be able to show the value of all of these innovative approaches, and that'll also help us set policies to see what things should we amplify and scale.
And I'll just kick in. We need to not forget about participatory research or engagement of our communities. It just goes back to who are we asking the questions, to whom, and I think that we often go in with ideas about what it should be, but I really do think we need to ask our communities, and each region where we all are based have different needs. So by asking our communities these important questions, it is a risk taking, but a lot of times it comes back to, is it reliable? Is it credible? All of but I think it can be added to the other studies. So participatory research to me is really important. And I have certainly seen it empower people to feel that they're a part of the decisions, the outcomes.
I want to switch topics slightly. We've gotten a couple of questions about the need for a diagnosis in order to get treatment. And this came up in the keynote at the beginning as well, with the discussion of should we be focused on prevention and mental health promotion? Right now our system is very focused downstream, so to speak. What are your thoughts about that? And what policy changes would need to occur in order for us to be able to focus on mental health promotion rather than treatment of disorder?
I can jump in on that one. I mean, I completely agree. I think the further downstream that we can intercept disease or not even disease, but just treat mental health as we do physical health, like I I used to go to the gym pre-COVID, just working on mental health every day and infusing it into all aspects of life, whether that's school or home or prisons or various places. But I think, again, this goes back to then what are you measuring, and how do you prove that this is something that's going to move the needle downstream, so that if you do this prevention measure, someone is going to not relapse in their depression or their substance use, or even get their first episode of depression. So I just think there's obviously some data on it, but I think there's got to be probably more targeted data. And to Glenda's point about measurement, we do have the PHQ-9 and things like that, but I think we're going to have to evolve to a system of a little bit more like we're doing stepped care, like a stepped measurement system. So now if you get high blood pressure, you then go off and do other labs. Right now, if you have a high PHQ-9, like that's the end. And we need to evolve so that we can, maybe do a Columbia suicide scale. But I think there needs to be more measurement pathways so that we can really understand where people are in their mental health journey.
If I could follow up on that with any of you, but is primary care potentially a more appropriate analogy and model for thinking about this than specialty care? That is, my insurance covers an annual primary care visit. It's not necessary that my primary care doc enter a diagnosis for me to see him, and there's a lot of screening that happens, both formal and informal, during that primary care visit. Should we be thinking about mental health in the same way?
I can jump in because I have training grants right now that actually do that. We have nurses embedded, nurse practitioners that are taught to work to the highest level of their scope of practice, which means that they have some extra training in psych mental health. So they are providing that equal care in FQHCs, for example. So, making sure that even at every session or every time the person comes in, that they're using the PHQ-9 or the GAD. We're also screening for substance use disorders. But what typically happens is if, the agency decides they only want to do it annually, then it gets lost and that information gets missed. And so in previous work that I've done, we actually learned over time that it was really important to do that. And it goes back to it takes too much time. And so higher levels of admin will say, you're spending too much time with this patient. So then that taps into the whole notion of what are we paying for? So I just want to throw that out that I'm on the grassroots level. So I'm speaking not from, sort of the data as much as what I'm seeing at the ground in the trenches.
There's certainly several models where psychologists and other behavioral health providers are working right there alongside primary care providers as well, so that you can do that warm handoff, right? You walk in and somebody's talking about their sleep problems, they go see somebody with some expertise. I've long said, if I was queen of the healthcare system, everybody would get a couple of sessions every year with the behavioral health specialist, no questions asked, and think of the things that we could do. We could probably intervene around sleep, around other kinds of health habits that we know contribute to problems with mental and behavioral health. We could perhaps catch changes in mood or development of some kinds of phobias or panic disorder earlier before they become so entrenched and require longer care. But that's not the model we have in healthcare right now. But I think that would be essential to get towards, and that does mean people don't necessarily have a diagnosis. And that would really open up some doors and opportunities for people to just normalize the experience of talking to somebody with expertise in that domain, that you could get some supports and develop some strategies and skills to better roll with life's adversities before things become disorders, before an ongoing, and we will of course still have mental health conditions for sure, but we may prevent some of the things, or we may reduce severity of some conditions.
I think one thing, oh, go ahead. It was Glenda, were you talking?
Yeah, I was just going to say, along those analogies, that principle of like universal precautions and having that population health approach, knowing that everyone has mental health, everyone may not have diabetes, but everyone has mental health and everyone is at risk of losing it to some extent on any given day. So from a payment, from our existing structure, from an innovator perspective, if you're taking that population health lens, then it would make sense that you would want to have some interventions happen without having to go through your traditional multi-leveled complicated intake process, whether you're using technology to screen. We even face this issue with the model that has the range of care because, well, if the peer is the first one reaching out, they don't have a diagnosis. We have value-based agreements. And it's like, well, let's just put one out there we know is generally going to, we're kind of like making stuff up to fit within the system. But that policy doesn't really make sense if you have a population perspective. There's some level of preventive assessment care that's needed, and then you can properly segment your population and then tailor the interventions for those that need to go through the full steps of the process to actually even get a diagnosis. So I think that's a really important tension that we need to continue to wrestle with on as we design payment models and as we, those on the provider side, have the value proposition of why should you pay for care this way and how can you be sure that your investment is actually going to lead to an improvement in the outcome and lower costs, because let's be honest, that's what is another thing we haven't talked about, that the way that investments are, there's still a segment of the population that's consuming a lot of the costs, and that's causing part of the problem as well, looking at the population level.
And David, I was just going to mention, based on your idea of kind of integrating this with the PCP visit, I really like, so that it's sort of a one-stop shop and not a fragmented system. But that is predicated on kind of the notion that there would be integrated mental health in PCP practices, which has still been a hard thing to scale for a number of reasons. I completely agree, like in terms of payment and seeing value, I do think this is a moment in time in the culture and for payers and for health systems where they do recognize the importance of mental health and the impact on clinical outcomes, on finances, on sort of across the board. So I think it's a real opportunity right now to push that integration and that kind of downstream prevention, early interception of disease.
You all may have noticed, I don't know if you had a chance this morning, Emily Becker-Hames led an editorial that was published in The Hill called It's Time to Pay for Mental Health Care, and talking about the fact that this is a fundamentally broken system in large part because of underfunding. And Glenda, to your point about half of the workforce not impaneling with insurance, why would you? When there's such demand and I can make so much more money charging people out of pocket. How much of the challenges that we're observing in our mental health system are about chronic underfunding? And if it's not chronic underfunding, what else are we looking at that we need to think about policy levers to address?
I think we need to look at more models, that when one model comes up and basically that's the be all and the end all, which I'll use the collaborative care model. If you've ever implemented it, it does take many steps and there's lots of paperwork. So, in doing that, I guess it isn't the best model for many of the places where I have been. So I think we have to look at other ways of streamlining what providers do and how the accountability, yes, it needs to be there. But if you've ever looked at the paperwork and how you have to meet all the different bits and pieces and then what you're actually reimbursed for is not equal. The time is definitely not equal. And that's why psychiatrists have left their residents not going into psychiatry. So now we're depending upon nurse practitioners who are filling that gap. But, the issue still is they have to follow that paperwork and spend all of that time when they could be working with a patient and seeing that patient.
Cass Sunstein and Richard Thaler would say we have a lot of sludge in this that's making it challenging for for clinicians. Thank you. Other thoughts about, is this all about the money, or are there other levers we need to pull to address the challenges in this mental health system?
Well, I would just respond about collaborative care, because I think this will speak to your broader point, David, which is that there's sort of money in terms of, direct payment, but then like take collaborative care for an example. That's a system which is hard to set up and needs sort of upfront infrastructure investment, and then potentially needs ongoing kind of technical support, especially for the complicated billing codes. So I think there are mechanisms, for example, to do infrastructure payments or set up sort of centralized support centers for different models of care. And so that way you're sort of incentivizing the scaling of evidence-based models, while obviously also there's a lot that can be done with the payment system itself. But I'm just trying to think out of the box about other ways to incentivize these kind of newer types of models. Thanks.
Something I've been thinking about related to that, David, is there a way that the innovations like Talkspace and even Calm that are kind of more societal level, what can they do to help us in identifying, risk within their populations? We have such great multi-diagnostic ways of delivering even technology to help with diagnostic capacity that I think might be interesting to think about. How does that flow into other systems and eventually the traditional, even community mental health or traditional mental health system of care, which there'll always be a need for that. There's always going to be a need for acute care, and figuring out ways that we can sort of knit together on the margins of where these different systems are doing well. I think that's, it's that issue of payment, but it's more like, even payers, they want to be smart with how they're investing their resources, and everyone's coming with a nice PowerPoint deck of how they're going to solve other problems. And so it's important not to demonize the payers. They have the same challenge that other investors have. But I'm very interested in thinking about how innovations that are kind of community-wide or societal-wide, how can we kind of, those of us on other ends of the spectrum, interdigitate with that to make sure we can have case finding and segment our population so that we can really have like precision mental health care in a way that we think of it, precision medicine and how they formulate thinking about populations.
I couldn't agree more, Glenda. And I think, as we talked about before, there's sort of precision care, but then there's also precision measurement. And as we get closer with there's some promise with digital phenotyping and biomarkers and things that might be a little better, but also precision engagement. Right? Engagement shouldn't be measured as like a generalized, okay, just because you went to more visits than this person, that means you got better engagement and better mental health care. Like different populations will need different types of engagement, different frequency of engagement. And so really understanding that, I think, will help make the healthcare system more effective and more efficient. And then some of the payment models can be kind of driven by that efficiency.
Is there an enforcement issue here as well? That is, Ben Miller talked about the lack of enforcement of the Mental Health Parity Act. One of our attendees made a comment and question about network adequacy within mental health. Are there regulations, laws already in place that we're not enforcing as we should to increase that access and quality to mental health care?
I would say just the first thing is to keep in place the telehealth sort of emergency order so that there can be, across state line telehealth. That alone would be a huge regulatory win, I think.
Great, thank you.
And Karen,
go ahead,
Victoria.
I'll just quickly say, and the audio piece, because, I had a patient this week who said, I can't do telehealth. They don't have the resources. They don't have a smartphone. So I do think we need to also not just lop off the audio portion. Older folks tend to use the phone and they find that as beneficial. I think with the Sunshine innovation calls, I think that goes to say that's how important that is.
Yeah, we haven't talked about medications, but I'm on my state's Medicaid Drug Utilization Review Board, and very often I'm making comments that reflect that lack of parity to say, why are there all these prior authorizations required for first-line medication treatments for serious mental illness? What's the reason for that? What's long-acting injectables? I've been helping to educate them to say this is really important to be able to minimize any potential barrier to a prescriber being able to deliver these very effective treatments to first episode psychotic patients. And if we're not part of that conversation, then there's no one else that's going to raise that issue. And then, so I think it's going to require a lot of engagement, even at that micro policy level, and not just the, federal level or state level, even at the micro level, the way that formularies are built, all of that impacts barriers to access to quality care for mental health.
Lynn, were you going to add to that as well?
An additional point to Victoria's point about older adults perhaps not having access to video conferencing, that I have several patients who have access to video conferencing but no privacy for it. So that's another reason why audio only is very essential, because they can leave the house and do a session sitting in their car and not have mommy going on the entire time. So I think that's really an important aspect too. And the data supports, we have as much data on phone only, audio only in terms of mental health, because it's been around longer. It's effective. There's no doubt about it. But we do have to think about the training and the needs of providers in order to effectively deliver care using different modalities. That's a clear process that we need to be thinking about in terms of who we're developing as trainers and deliverers of that kind of care.
Right, so the real nitty-gritty and details of what it is that we cover, and Glenda, I think to your point about how much unintended barriers we put in place, how many unintended barriers we put in place with the sort of a small stroke of a pen that changes that, where we really don't think through some of the larger policy implications at the local level of some of these policies that we make. We are starting to run out of time. I have two more questions for you. This has been a great discussion, and I'm really very excited by what you're sharing. The first is, one of our attendees asked if you have any examples from institutions or jurisdictions like states that are making really innovative reforms in either how they pay for care or how they deliver care that you think we should pay close attention to or even emulate.
I've worked a lot with First Lady Shirley McRae in New York City, and they have a lot of different innovations that they've been working on, looking at the power of mayors, and there's over several hundred mayors across the whole country that are part of a Cities Thrive network of elected officials trying to think across multi-sectoral systems, so not just healthcare but education, labor, transportation, to think about how they can look at mental health from a population perspective. So I think, they've made a lot of investments in mental health first aid, which speaks to some of the issues we talked about, that continuum of care from just living your life to, I have a problem, to what do I do now, to making sure that there's resources within the community to help people access care. And I think that's a really important point. I know a lot of states are also, like North Carolina, have been trying to look at, how they implement collaborative care across the whole state. How do they look at being innovative within Medicaid and Medicaid expansion to try to increase access to care, but also implement some of these innovative but hard to do unless you're incentivized financially to implement, different models of care. So those are just two examples that I happen to have been somewhat involved in that I think were really exciting.
Thanks.
I think the VA has been a pretty good model in some ways for just the continuity of care, right? And the way providers can talk to each other, because so many other systems, my GI doctor doesn't have any idea what my OBGYN is doing, who doesn't really have any idea what my primary care provider is, and I'm reasonably educated and know how to access healthcare, but they're all independent providers and not engaged in a system. And so figuring out ways to create those systems so that mental health is part of that, that the other providers are part of that in a way that still protects patient privacy and confidentiality, which has been a sticking point for many providers around that and concerns about that. There's so much promise, but as Glenda was saying, as others are saying, we need to make it accessible to the providers to get in those systems too, right? So we have to make it possible for someone to afford that technology and to be able to use it effectively. So that would be another critical aspect of it in order to ensure that we're catching behavioral health concerns earlier and that everybody is aware of what that interventions might be happening, right? So that as an anxiety provider, I'm often telling individuals that it's important to get out there and expose yourself to the things that give you distress. But I have had providers who are not familiar with mental health say, no, don't do the things that overwhelm you. So kind of counter to exactly what I'm trying to work on in treatment, because we don't have those kinds of conversations easily available to us in the way our system is set up. So we need to find ways to make that, to capitalize on the promise that we thought electronic health records would bring to all of us. And that really hasn't happened.
I think one thing I would add to this conversation about models, one is that there are a number of states that are taking really innovative approaches to leveraging Medicaid to provide mental health care in non-specialty settings. So, for example, Massachusetts, which made its schools, its local education authorities, Medicaid licensed providers, or Pennsylvania, which especially Philadelphia, which leverages Medicaid dollars to place mental health clinicians in schools to provide care on site, really getting to this issue of bringing care to where people are who need it. I would say one real gap in this area, and maybe there are other people who know of places that are doing this, but we haven't touched on the fact that jails have become the de facto, and prisons have become the de facto behavioral health care setting in our society. For many unfortunate reasons, and that we have very little idea about the quantity or quality of mental health care that happens in those spaces and its connection with the evidence base, or lack of connection with the evidence base. There's very little accountability, and often we're trying to pick up people just as they come out of jail to engage them in care. But I think we do need to think about more innovative models that link mental health care with prisons and jails to start people on care and continue that care once they leave. All right, last question for you all, and I'd like to go around again as we did at the beginning, which is, if you had to take one lesson that we learned from this pandemic about issues related to mental health and mental health care, and carry it forward in policy post-pandemic, what would that lesson be? What did we learn that we should continue to do? Or it could be something that we screwed up that we now need to that we should be fixing as we move forward.
So I'll jump in. I mean, I think to me, what comes to mind when he said that was kind of flexibility, or kind of the dynamic nature of care that happened during the pandemic. So constantly sort of moving and evolving based on context, kind of flexing to individual needs, being part of a fluid system and sort of a force for change more broadly in healthcare and society. And also just the speed at which I think places were able to kind of test and iterate and change the system during COVID. And, I think where the gap is there is making sure that while there's speed, that we're listening to all voices, and especially those who've been marginalized in the process of building the system, and also to be sort of patient focused and really meeting people where they are, and not just doing kind of a one size fits all solution.
Thank you, Cecilia. Lynn, would you share?
One of the things that I thought about is the challenge for really having population well-being. And it was evident as the pandemic began and progressed, the first months, how fragile that really was. That the kinds of supports and skills and structures that we hoped people had when everybody in the society is impacted by something like the pandemic, it kind of crumbled. So how do we move towards having a seawall that protects people from the next national adversity in a way, right? So that's it, and that's not the role of individual specialists, but it is the role of our disciplines within mental and behavioral health to think about how do we bring well-being as an emphasis, that it's not an afterthought, and that it's really integrated into overall conversation about health. That would be an important place so that we do not see the falling down and the huge increases in substance use problems and all kinds of concerns that we're seeing in data right now. That there have to be ways to ensure that people are better equipped to deal with whatever is coming.
Thank you. It sounds very much people were talking about the public health system in general. You don't realize how broken something is and how much you need it until it's stressed in the way that things were stressed during the pandemic. Victoria?
So I have a couple, I'll say them really fast, but the first is we have to give up the phrase that we've always done it this way and really throw that out, because we have to look at that goes with the flexibility. The second is health literacy is so important. Educating the consumer, the patient, the client about their options and explaining it in a way that they can understand. One of my frustrations is even when I hear, people at the top explaining about the booster shots, there's so much inconsistency and there's a belief that they know, that everybody knows what they're talking about. We have to talk in a way that people understand. And my last piece is to remove the barriers. For nursing and nurse practitioners across the United States, they're willing and able to treat substance use disorders, but they have to have a collaborative physician. And in North Carolina, that has created enormous problems. I know there are states that have moved ahead, but that barrier is just really has made it very difficult for nurse practitioners to be able to practice in rural areas. And North Carolina certainly has the majority of the state is rural.
I appreciate your bringing that up, Victoria. Thank you. Glenda, I'm really happy to give you the last word.
Well, I was actually thinking about, taking us back to Ben's challenge, to us in thinking about, will we take this opportunity and make the most of it? We had the opiate crisis. The pandemic happened right on the heels of that. So if you didn't catch it with seeing how close you are to the opiate crisis, for sure the pandemic brought these issues around mental health to everyone's front doorstep. And there was nothing more prominent that I saw was a deterioration on my personal social media of friends and colleagues completely unraveling under the weight of compounding stress, the economic impact and stress, the huge levels of loss and grief just from loss of life, and how many people are struggling with this and trying to figure out how do you maintain efficiency at work. So those were the main things that really stood out to me around the pandemic. And I'm challenging myself and thinking about how can I take up Ben's challenge to say, what will we do now that the focus is now on this and everyone sort of cares? Will the people with answers stand up so that the people with no, we all have a little something. You might have resources, you might have policy influence, you might have all the research data. Like, can we figure out how to really overcome some of our disagreements on the margins around policy and really get behind the shared things that we all agree on? Because, those of us that have done policy work know you really only have a small window of time around a focusing moment to get something through, and you have to get everything that you possibly can because you may not have a chance. People say, oh, we did mental health last year, so we're not gonna, we're not gonna do that. I hear this all the time working with policymakers. So I hope that I'm challenging myself. I hope we can all come away from today thinking about how can we really make the most of this opportunity.
Oh, Glenda, Victoria, Lynn, and Cecilia, I think you've challenged us all. I'm really grateful to you for sharing your experience and, more importantly, your wisdom. about where we are with regard to the mental health system, what we've learned from this pandemic, and where you think we need to go from here. So thank you again. With that, I'd like to turn it back over to David Grandy, our host.
All right. Thank you, everyone. Certainly a lot to think about, a lot to do, but a real urgency to act from everything we heard today. I think it was Glenda's comment who said, will the people with answers please stand up? I think we've brought together a lot of people today who have some real answers and provided a real roadmap about how we can move forward on the challenges we face in mental health care delivery in the United States. Thank you again to all of you, and I truly hope you all have a wonderful weekend.